Dr. Sujay
Yeah.
Samantha, please come.
So
You people can go this side.
this
Dr.
method
Sujay.
is, the people call it CLE, that is clear lens extraction, is also known as RLE, that is refractive lens exchange. It is the removal of the non-cataracted lens, which may be, you may put the IOL or you may not put the IOL. So there are controversy about the LASIK and lens. Let's not talk about it because this is not a subject. That there are pros and cons of both of them. So, you do any surgery, let's say pterygium or glaucoma or cataract, there are some problems that occurs in the cornea. And if you do the surgery on the cornea, I don't know, you are making so much of abrasion on the cornea. The all, structures of the eye has been tried, sclera and iris and everything they have tried. But I feel that the clear lens extraction is the best way. What happened to the slide is not moving? So I'll be talking about the CLA. Now, नहीं मूव करा यार, कुछ करो. Dr. Bharti, this is कोई साजिश है ये? Then what is happening? She is my wife. घर में भी लड़ती, यहाँ भी देखो. यार.
Your own student? No, no, we don't think we should. ए भाई अपना अपना सीक्वेंस देख लीजिए ना आगे.
Well, there's video that is going on, you see the lens is flipping. Even an uncomplicated case can have some complications like endothelial loss. Flip off is a major problem. And the number of holes in the IOL is increasing day by day. And loading the IOL is very, very important. If you damage the lens, you are in trouble. And that's why the companies, they're giving you one spare lens. So this is not without complication. That's why the company is giving you one more lens. Try that. Faking lens, you have to see the aqueous depth. It has to be more than 2.8. If it's less, you're gone. You can't do it. You have to have the measure the white to white measurement. And the manual is supposed to be the best. You can't depend on the machine. And cataract has to develop, especially in the cases of myopia. There are a lot of factors which can create cataract at a later date. That is because of deformity, because of the zonal problems, because of the vitreolysis, and there are retinal changes and they all accumulate and give rise to posterior subcapsular cataract. So at a later date, you'll have to go for another surgery if you put a phakic IOL. So this is how it's done. Then if there is a larger IOL, you will get glaucoma and cataract, and then of course there are unstable toric lenses if these lenses are smaller. And let me tell you, you do not have a correct IOL power calculation for IPCL, the phakic IOL. You cannot. You don't have. You have to take the measurement, give it to the company, he'll make it, and you have to put it in whatever they give you. And look at clear lens extraction. What are the indications? Myopia, which cannot be, which is not contraindicated, and which cannot be if the LASIK cannot be done, and even hypermetropia, when it is contraindicated in those cases, and then you feel that the result is going to be inadequate. What are the indications of the clear lens extraction? If there is a retinal disease, very high myopia, a higher rate of retinal detachment exists, and the other types of refractive error are there. Prophylactic treatment of a peripheral retina, especially in patients with pre-existing abnormality, has to be done. And prophylactic 360 degrees, many people, they do it. Probably contraindication of CLE is contraindicated for all refractive surgery. There is a high refractive error. The patient is not fit for corneal way of refractive surgery. I'll not be talking about the normal precaution that you take for the normal cataract surgery. You have to do a proper IL power calculation. If the patient hypermetropic, the patient is never happy with the contact lenses. The patient is never happy with the glasses. Somebody will give him +1, somebody will give him +2. So the patients, they are never happy with the LASIK, except if the patient is given a clear lens extraction. So these are the investigations that you do. That is refraction in the dilated and non-dilated people, retinoscopy and eye tracer refraction, OCT of the angle of the anterior chamber depth, clear cornea on slit lamp, the specular microscopy for endothelial health, Shermer test, the membrane gland function test, intraocular pressure, soft set-based optical biometry, fourth generation IL calculation formula, apply your own SI and A constant if calculated. If there might be lens thickness, you have to calculate that. Check the toricity of the IL and use the IL that you are comfortable with. And final IL power after image guided system, that is we use very on.
There will be some overlap.
So there are the aberrations in the cornea and in the lens. So if the patient is high myopic and you have a lot of aberrations in the lens, you can go for a lens extraction. It's indicated. The other things like, the latent lacrimal sac pathology and diabetes, you have to exclude all those things, and also the deep eye socket. The eye tracer refraction is very, very important. We do refraction by all means, even cycloplegic refraction is done, and refraction of the tracer refraction is also done. And you have to see too that the angle alpha and angle kappas are fine, so the lens is centered properly. The AIOS depth is important because if it's less than 2.8, you don't do it. So there's a dysfunctional lens index. Less is the number, more is the trouble. Is a normal eye, you will get approximately 7 to 8 DLI. Investigations, you have to do the pachymetry also, B scan for staphyloma and shallow RD. Indirect ophthalmoscopy with indentation is essential. Cover all the lattice by laser if they are not pigmented, and all suspicious areas should also be covered. Rule out the keratoconus by topography and abrometry. Counseling is very important. If the patient is motivated that please do LASIK on me, you don't have to do the LASIK for them. If the patient is motivated, do the I want IPCL. You don't do IPCL for them because the patient is motivated. So this is a very wrong term. You have to counsel them and counsel them more aggressively if you feel that it should be done for him. And what I do is I do the retinal examination before the surgery and advise retinal examination immediately pre-operative surgery. I advise them for retinal examination at post-operative. Operation khatam ho gaya, retina janch every year. And at the time of discharge, I tell them retinal examination every year. So, look at the hypermetropia. The patients are not happy with the contact lenses, with the glasses, which are not happy with the corneal refractive surgery. They have got shallow AC and crowding of the angle, and they're not with the phakic IL. Glaucoma and endothelial damage are there kept for you. The under diet regulation, the curta is tight, central vitrectomy should be done in cases of hypermetropia, and so in cases of hypermetropia, if you are going to do the CLE, you should preferably do a dry and the anterior vitrectomy, and try to avoid the IOLs. If it is toric IOLs, if it is toricity is more than 2.5, I always undercut it by 5% for the IOL in hypermetropia. For the myopia, it is just like a normal cataract surgery, and do a little larger recess so that most of the soft lens can come into the anterior chamber, and then you can do the phacoemulsification easily. And AC is never deep necessarily in all the cases. SCTR should be used in cases of a toric IL if you have to put. And every time you have to put the visco every time when you withdraw the phaco probe. The bimanual IA is very helpful. Inject OVD before you withdraw the irrigation probe, and hydrate the wound before withdrawing irrigation probe. And I always put a little air at the conclusion of the surgery so that the anterior chamber is maintained and the lens is pushed a little behind. Well, there could be intraocular lens dislocation, there could be hemorrhage, there could be capsular rupture or dialysis, malignant glaucoma, suprachoroidal hemorrhages, wound leak, retinal detachment. Yeah, nothing is without complication. But then, what is the way? There is no way. You have to do this clear lens extraction, and that's the way to go. Think about it. Think about it.